Hey guys, Don here. Welcome to Podiatry Practice Mastery, going over what helps get to the $1 million mark and beyond. So we are about 4 weeks into the ModMed transition, and things are going much better. I only had a few notes at the end of the day that I couldn't finish, and I'm getting home by about 5. So Morale, my scribe, is getting into the hang of things. The day was a good day. My funniest thing of the day, there was a patient that came in. He's like a 75-year-old guy, and he says, "Hey doc, how come my toenails are all black?" And I looked at his toenails, and they're all just like black lint on them. And and I was laughing, and I looked at his socks, and his socks were black. And I said, "Are you using something for your toenails?" He said, "Yeah, the other doctor gave me the cyclopirox stuff here, and I've been putting it on." I said, "Well, you just didn't let it dry enough, so that's why you got all this the black stuff on your toenails." So I don't know if that's happened to you, but it tends to happen mostly for guys. They don't let it dry enough. Okay, so let's go through the day. First patient, 47-year-old female. She got a new patient, had nail fungus, got the fungal nail kit, which is a UV light, the UV light, the shoe spray, and the biotin. And then she got, I did LFTs, and I prescribed the terbinafine all in the same visit. I'm offering patients to avoid the nail sample because a lot of times they're charged a lot for that, and it just makes it easier. Next was Swift 4 out of 4. This is a 23-year-old female. She's an MD PhD student. Her warts are almost gone with Swift 4 out of 4, and so we're going to see her back in 3 months. So unlike the shockwave, at the last shockwave, I'll do an office visit. Usually at the last Swift, I'm not really doing an office visit. I'm just doing the charge for that. The next patient was a 71-year-old female. She had a painful left fifth callus on the fifth met head with a possible bursa underneath there. We talked about orthotics, and I got a no. So I think getting no's are really good. I think you have to learn how to offer things to patients and get used to them not accepting orthotics. I trimmed down her callus. She'll see how that does, and she'll come back as needed. Next was a 19-year-old young man, office visit with an IND for his hallux. Next was a 70-year-old gentleman who had possible gout and a possible foot fracture. It was difficult to tell. Looked more like gout. I put him on Celebrex. He had his own cam boot he's going to wear, and I'm going to see him back in a couple weeks and see how he's doing. I'm not exactly sure, and we ordered a uric acid for him. Next patient from 47-year-old male. He had that initial terbinafine visit like before, and now he's here for the 3-month follow-up where he's going to get the booster dose. So these are quick 10-minute appointments. So we got the booster, and I don't see him back, only if needed. Next patient was number 1 out of 4 for EPAT. This is a patient that has a lot of ecchymosis and edema around the lateral malleoli. She has just a transverse fracture there that doesn't need surgery. And she's a very, very active pickleball player, and she wanted to do everything she can to speed it up. So that's why we are doing a series of 4 shockwaves. So I do the radial all around the soft tissue to help get down the swelling and bruising. And then I'm doing the focused, or actually this is softwave, right in the area of the fracture site. So this is number 1 out of 4. Next patient was a 74-year-old female that had kind of a painful callus on top, the dorsal medial hallux, because the second toe is rubbing on top of it, and that callus is really painful. So we scheduled her to do an exostectomy. I think an in-office exostectomy is probably, next to a flexor tenotomy, one of my favorite in-office procedures to do. Next was a nail fungus patient. She really didn't want any treatment. She was 74. She was just concerned because her nail salon said that she had some fungus. She had a little streaking in the nail underneath it. It was in a position where it was really hard to take a nail sample without destroying her nail, and it's summertime coming up, so I said just get a pedicure, and if it gets worse, let me know. Next was a 81-year-old man came in. This is the guy with the black toes. So I just debrided his toenails. And I said, if you're my father, I wouldn't put you on the pills. Just come back and do your nails here with my nail tech here in the office. Next patient was a 34-year-old male. This was kind of a challenging one. He was seen by his PCP, and he got an MRI. They didn't really read anything on the MRI, but he had a kind of a weird-looking fourth metatarsal kind of base region. And I think it was a possible old fracture or a new fracture or something. So I evaluated it. I used the fracture code, and I'm going to see him back in a month. And I talked to him about shockwave. for like a possible delayed union. It's been 2 months, still hurting quite a bit. Actually, not hurting quite a bit. It's hurting like a 3 out of 10, but it's in an inconvenient place and it's not getting really better. Next patient was a 76-year-old gentleman that I've been seeing for a long time for an ulcer. His ulcers were all healed. He was planning on getting into a new AFO, and unfortunately that AFO caused him to ulcerate. And this is the second time this has happened. This is frustrating. I send these to Hanger for this, and he ulcerated. I think it's not so much the AFO. I think it's more the shoe that was too narrow. It's one of these leather shoes with some seams on kind of the lateral fifth aspect, and his bone was sticking out. So I brought it down to bone, and I'm going to refer him to one of my colleagues to do an amputation of that toe. And then I'm a pretty good relationship, and I said, and now your shoes will fit. The shoes won't be a problem because you won't have a toe. He's also on doxycycline. So the reason I send it to my colleague is because when I have a busy schedule, it's hard for me to schedule surgical time. Like, it's not a raging infection that I need to do it at nighttime. It's a scheduled procedure, and one of these other younger doctor has a little bit more flexibility, whereas I'd have to cancel a day, and I only have OR time once every 2 months. Next was a patient status post amputation, so amputated the second and third toes. She's doing well. She's going to do another post-op suture removal in about 5 days. Next was a young little girl, 22. She had bunions bilaterally. One was a little bit red, and I think it was due to shoes. So I spent a lot of times talking about anatomic shoes. I gave her my recommendations are Anya's Reviews, which have a great selection of girly shoes, and then Ultras and Topos, and then Lems. So I talked about shoes, and I think that'll be enough for her. Otherwise, then I said shoes 1, and then correct toes spacers 2nd, and then orthotics 3rd if needed. The next patient was a 64-year-old female with EPAT number 3 out of 6. She has some peroneal tendinitis pain. It's actually already starting to get better after the 3rd visit, which isn't common. Usually it's around the 5th visit that they start to feel better. But she has goats, and next time she said she's going to bring me some goat cheese, so I'm kind of excited about that. That's my favorite thing, is when patients bring in food. So usually my favorite is like Middle Eastern, like baklava, hummus. So if you ever want to send me a gift, you guys can. Okay, next was a 59-year-old female. She's here for a fracture second opinion to her toe at her middle phalanx. The distal medial side had kind of a displaced, impacted fracture that went about halfway through. Was seen by another doctor. She might benefit for shockwave in the future, but for now, just giving it more time. It was buddy taped, and she was in a cam boot for about 2 months, and it's still hurting her. So I said that can sometimes turn into a delayed union, and the other doctor talked to her about possibly doing a bone stimulator. I talked about either that or a shockwave. She also had a kind of an embarrassing thing. I always like to share the good, bad, and the ugly. So she made a big fuss because she went and saw this other podiatrist, and when the podiatrist looked at her orthotics, they were actually on the wrong feet. And that wasn't the bad part. The bad part was she had a limb length discrepancy about 3/4 of an inch, and the addition was placed on the wrong orthotic. So her right side was shorter. The addition was placed on the left orthotic. That's why she thought the left was the right. And when I went back to look, these are like 7 years old, and she's been wearing these on the wrong feet for like 7 years. And I looked and I said, well, why didn't you make the follow-up? Because usually I dispense orthotics. She only in one visit scanned her for orthotics, made the orthotics, and she never followed up. Because usually I would catch that. And she said, well, because I didn't want to pay the copay. So I find sometimes patients with a follow-up visit for dispensing orthotics, they cancel that because they don't want the copay. But in this case, that would have been a really good thing. But that was embarrassing. So I made a new pair of orthotics, and I'm not going to charge her for that. But I am treating the office visit for that fracture. Next was the mother and son. Basically, this was probably the MVP patient because they both needed orthotics. Mom got the first pair, and she paid full price. Son got a pair, but I only charged $100 because he already had a pair and he had the pediatric outgrowth. So the orthotic company that we use, they do a pediatric outgrowth, so they can get a second pair, whatever we deem necessary, for only the scanning fee. So that was the day. It was a good day. As you can see, I'm a little bit happier now. I was pretty disgruntled for the last couple of weeks. I apologize for everyone for being a kind of upset, but is the whole medical record transition thingy. But things are getting a little bit better. I can see the birds are chirping. Everything is getting a little bit better. I'm less stressed. I'm not eating at work, and so things are good. I'm kind of proud. I think I was telling you before. I got asked to do an article for Podiatry Management, so I wrote the first one on. It's going to be called the $1 Million New Practitioner Series. So how to get new practitioners to the $1 million mark. I am doing an inquiry here. I'm asking people if you have things that have worked to get your associate busier faster. I would like to know that, because we are, like most of the doctors I talk to, the doctors range around 20 to 30,000 in revenue each month, and then they ramp up slowly. If you have tips about ramping up quicker, besides just getting the overflow from you, other things that have worked, have worked, I'd like to know, so I can include that in that article series that I'm going to be doing. It'll probably help us out as well, because we're struggling with the same thing. Okay, so once again, have a great day, guys. If you want to email me at don@podiatrypracticemastery.com. Thanks.